I'll be speaking about, what protective measures we can take against this COVID-19, which is, undergoing a lot of metamorphosis all the time, and so this is my photo, which I just took yesterday of my OPD, how we are working. You can see that there is a lot of, sanitization here, and my full OPD is like open, these are the doors here, windows here, which are open out, and there's a door here of the entrance. So, we have kept the full place very open, and we have good spacing between patients who are sitting. There's a lot of sanitization. There's UV lights, which are there here, though they are not on now, but they are used when after the OPD is closed, and then we sanitize the full place by using multiple UV lights in this here in the tube light. They are available as tube lights itself, very nice, which Dr. Abhishek would be telling us there. This is a thing we have kept a little to keep a distance when the patient is talking to my receptionist here, so she doesn't bump into very, very close to her. And cross ventilation is the key, I feel now. Initially, we thought it was droplet, but I think now we are very sure that it's all airborne. So, the bacteria the virus do stay in the medium, floating about for a few hours. This is my consulting room. So here, first thing is that there is no seating. I've removed that 2 chairs which we had of the patients used to sit next to me and discuss. Here, I don't know, this is looking very transparent, but I've got a very big sneeze guard here, which is like, how you have at the counter in the banks and everywhere, you have a transparent, a sneeze guard, which I got from Amazon, which is a very nice device, which, sort of tells the patient that, stay away from me, It's very effective if you have, something which is droplet borne, but in a airborne, I think, it's not that important, but it creates a sort of impression to the patient that, he should keep a distance. And this is my OCT here, where the patient sits here and I stand a little away from him. We have minimum talking, this is the slit lamp guard, which we have, the sneeze guard again, which we apply on the oculars, which were made by Zeiss and also by local people. In the very initial stages, I had to use indigenous modification by using X-ray films and everything. So over these 1 year, we have evolved ourselves, and now we are into the vaccination stage. I was very skeptical when this thing started that how soon we'll get the vaccines, but our scientists have done a great job of getting the fastest, vaccine delivery within a year, So I think a rapid coverage of the whole population and a widespread coverage is very important in these patients, I think, to control this disease is what I feel. So technology has to be used to the maximum, though elder doctors like us are still learning technology, but we are getting to learn more and more. So I have moved on to Google Pay for most of my patients, if they can, that's the easiest way which we can, pay without losing money out to the credit card companies, where they charge you a lot of premium on every transaction. So far, I find Google Pay is the easiest and a very sort of glitch-free system to transfer money very easily. Then teleconsultations, which should be discussed in detail, you have, you can have, various sort of programs like, on the Apple platform you have, which you can, actually do a video consult and see the patient and discuss with him and, take a close-up of his eye. Like I had one patient, for example, who was saying, I've got redness in my eyes. So I just said, you take a photo and send me, or do a FaceTime with me. Then immediately I saw on his face, he had a multiple herpes zoster papules, pustules in the region of the ophthalmic division, And so I realized that, oh, this is not a red eye or a pink eye, and it's a herpes zoster. So just by this simple consultation and get a close-up of the eye and the face, we could pick up quite a few things, like even scleritis, or maybe, sometimes the ciliary congestion versus a pink eye, with these advanced technologies. So in OPD procedures, what I basically say is that no mask, no entry. I think, we provide patients with masks who don't have at our reception, and we sort of tape up the nose part of the mask, so he doesn't try to, because every time a patient puts his chin on the slit lamp, the first thing he does is he brings his mask down over the head as though I'm examining his mouth, like a dentist. So I would say that no mask, no entry, and tape the mask over his nose, like how we do in the OT2. So it works 2 ways, that the patient can't pull it down. Usually they don't pull it up, and then it prevents the fogging of the eye when we are examining also, and it acts as a good sort of safety precaution for the patient also to be aware that the mask is extremely important in this clinic, and you triage the patient down. On the ground floor itself, I have my OPD boy who's got a thermometer, a non-contact thermometer. So a patient with fever and sore throat or cough is straight away told to go back home unless he has an emergency. And symptoms of loss of taste and smell, as we are aware of, or breathlessness, any other symptoms which are suggestive of COVID. We also have a pulse oximeter in our OPD at the entrance if a patient wants to check it. That's the easiest thing I think we can do in these times, for the happy hypoxia, which we are aware of. In the first pandemic, first wave, when we were just learning, we were actually very, very scared and we were just sitting at home. But the second wave has made us a little more braver. At least I'm a little more brave, and our we have sort of become a little more lax, you could say, because we are learning more and more about the disease, and we are also vaccinated. That makes us more confident in these times. So have you been in contact with anyone who has COVID-19 in your house, your friends, in the last 2 weeks? And are you from any containment zone or zone where there are too many cases, like, which we are aware of? So this is how our waiting room looks like, it should look like. I showed you my photograph. In Bombay, we don't have the ability to have such large consulting rooms, but if you could have a larger waiting room with more distancing and getting patients on appointment basis would, I think, solve a lot of problems of social distancing and frequent sanitization of the place itself, using sodium hypochlorite solution and and UV light again is what I again would suggest, which we have now. And just reduce the attendance in your clinic, like, with these old people. I've seen 2 people coming, 3 people coming sometimes, so I think if you make it strictly 1 attendant per person, or if it's a healthy young man or woman, no one should come, that also is important, is what I feel, to reduce the number of people, So I think talking less is advantages in various situations in life, as we have learned. I think keeping your mouth shut works even for COVID. So I think speak less, so you have less of droplets coming out from your mouth and less of sort of so I try to be sort of telegraphic in my even consultation when I'm talking, and like patients keep on asking questions after questions, and we tell them that it's not that I'm worried that you will get from me COVID, that I will get from you COVID. I tell them that I go to 10 hospitals and I'm worried that you will get from me COVID. So that makes them more positive, rather than otherwise you tell them to go away. They feel that we are scared of them. I try to put it the other way, that you should be scared of me because I'm the guy who's going to 10 hospitals and, might be infected. So they take that in a very positive way, So I think masking, double masking, and N95, which is now very freely available. I think it's a stupidity to wear any other cloth mask or any of these rags which we wear or these patients wear. I think we should all do a 3-ply mask now. There is no shortage. Or we should use these N95 masks, which are use and throw, because they have become quite cheap now. So as I've shown here, as per the iOS guidelines which were there when we started out, we were like, really looking at this per verbatim, and now everybody has found this sweet spot where to do well. So you have a 3-layer medical mask, N95 for your optometrist and yourself. Gloves, actually, I'm not very sure. I was using gloves initially, but I found it very uncomfortable. So nowadays, I don't wear gloves, at least individually, but I think we should leave that to the individual surgeon. And I used to sanitize my hands very often. And face shield also I'm not using anymore nowadays, So because that's a big hindrance for my indirect ophthalmoscopy, I've realized that. So front desk, you finish the maximum patient interaction, history taking and everything. So when it comes to you with the optometrist, there is, minimum sort of talking, is what I feel that is. And self-dilatation is what I suggest to the patient. If he can dilate from home, if he can come, or he pulls down his own eyelid and we just instill a single drop in his lower fornix, I think optometrists really help us a lot in these times, because they are the frontline workers, I would say, who take the history, do the NCT, do the basic refraction, which is, time consuming. And I think you should look after your optometrist and give them, high safety gear, which I give my own optometrist. You might wear a gown, but I don't suggest disposable gown, because I think the next epidemic, which I would say we will have, is of waste produced during pandemic 19. I think the way I'm seeing masks and these PPEs lying around, like rotting all over the place. I mean, that's the next pandemic which we will suffer much more, after this COVID goes away. So try to reuse, these gowns which we use, which can be washed and autoclaved and reuse, and cleaning every trial frame after every use with a spirit swab. This again, as I showed you, barrier between you and the patient, both are masked, and minimum talking is what I feel is the way to go. This is a trick of using a X-ray, to protect yourself. And these are the APO guidelines and how will you sterilize yourself from COVID, because the first warrior who died COVID was an eye surgeon who was warning the Chinese government, and poor fellow, nobody listened to him, and they tried to suppress him and he was lost. So 1:10 bleach solution, sodium hypochlorite, sodium peroxide, hydrogen peroxide, I think is little difficult for at least these optical instruments of us. And so isopropyl alcohol I've found is the best, to wipe properly for 5 minutes. So this is a point which I want to share with you all, that COVID-19 is an enveloped virus, and tonometer tip cleaning with 70% alcohol and allowed to dry is effective, But for adenovirus, which is quite common in our eyes, these are much more resistant to alcohol and require bleach in them. So this is the EU guidelines which I wanted to share with you all, that, try to reduce the number of patients coming to you if they have a rare disease which can wait, like retinal dystrophies or chronic retinitis pigmentosa type patients. Triage your important patients. Like, the first patient I treated during the first wave was a retinal detachment. He called me up about detachment. I told him, I'm not doing anything because I don't know what to do. Then there was another patient. So I got brave. And in the first month itself, I did 2-3 detachments, and I did a vitrectomy in all of them and tried to finish as early as possible. So I think anti-VEGF injections are a very important thing, and we want the patients to come back to prevent irreversible blindness. Eye emergencies are also not to be taken very lightly. I was actually going to my ROP screening, for my preemies throughout the pandemic, and we had to do them because there's no two ways about it. So we have to be like, So personally, what I do is sanitize my hands and surfaces after every patient, wash my hands after every 3-4 patients, keep my staff to minimum around me, keep the patients minimum around me, and try to keep as many possible over telephone consultations or, over phone. And if any of my patients my staff show symptoms, we immediately tell them to rest at home and get yourself investigated. So patients are equally frightened and unsure as we are, acute uveitis, acute glaucoma, retinal detachment. I saw a couple of patients, COVID uveitis I have seen with, Poschner-Schlossman. So I think,
Sorry to interrupt, sir, but the time is up. You need to conclude. I'm really sorry.
Okay. Yeah, fine. No problem. This is my last slide. So patients with other disease should also be counseled, and we should be aware to spot the treatment and come to us in time. So atypical manifestations of COVID, you should keep it in mind with mucormycosis coming up in big time. Thank you very much for your very patient hearing. Thank you so much.